Hi, Dr. Prakriti. These scenarios again we see often, where an elderly lady of around 75 years of age comes and tells us that she's not able to complete her evening walk because every 15 minutes she feels like using the washroom, but when she goes and tries to empty her bladder, the flow is very less and she has to put pressure, and she always has the feeling of incomplete emptying. So in this particular scenario, what is it that you are suspecting and how do we figure out how we help her?
So first of all, when certain symptoms, if the patient is coming to us with certain symptoms at the age of 70, it should be well received because many of them don't open about such symptoms. So when she comes to us with such symptoms, we need to do a detailed history taking as to which scenarios is where she is facing the problem, because not all urinary issues can be pathological. So that is where we as urogynecologists come in and differentiate. So once she comes in and she gives her symptoms and we decide that there is a problem, we need to do a detailed evaluation of her gynecological organs. So most likely the symptoms with which she has come with is somewhere where she is not able to void completely. That could be, when something like that happens, our immediate thinking would be either a weak bladder where the bladder is not able to push out all the urine, or it could be the passage which is narrowed down, which even though the bladder is pumping, the passage is not able to bring it out completely. So that can happen with age or with due to menopause, or very rarely any trauma to the spinal cord or the nerves affecting, and also commonly due in elderly diabetic women as well. So we do a detailed evaluation in terms of ultrasound to rule out organic anomalies, and a urodynamic study to study the function of the bladder, how it does, and then offer her various treatment options. So treatment options could be anywhere between a conservative management where we give them guided biofeedback pelvic floor physiotherapy. If that doesn't work, we do have certain surgical options as well. So when it comes to surgical options of such treatment, we need to know the cause of what is causing this. So if it is purely a urethral passage which has narrowed down and none of the medications or pelvic floor physiotherapy is helping, we go in under anesthesia and try to open up the passage a little for her, and then that, which is when she can empty the urine completely. The second thing is where any prolapsed organ, that is the bladder, which is causing her to retain the urine, and a weak bladder, and it is not letting the urine come out completely, and she is constantly under discomfort. If that is the scenario, then we can do a surgical repair either through vaginally or through abdominally. So when we do a vaginally, it will be just a repair. When we do abdominally, a more definitive procedure would be to incorporate a mesh and anchor the bladder to a stronger structure so that she is relieved of her symptoms.
Yeah. So both procedures based on the patient's comorbidity, both are equally effective is what you. So in the same scenario, if it is a younger patient, say around 50s, and she is not able to sit for her presentation. Every 10 minutes she needs to use the washroom, and when she is laughing loudly in public, she feels there is a little bit of soiling of her undergarments. So where she has a mixed urinary incontinence picture, how would we evaluate and treat her?
So again, our basic steps of a detailed history and examination will be considered. So when it is a scenario of mixed, where the stress urinary incontinence, where she's stressing on the belly and she leaks, that component is also there, and repeatedly in an hour's presentation she has to go repeatedly, gives us a picture towards urge incontinence. We'll have to balance out which is the most bothersome symptom, because if it is the urgency which is causing the symptom, the most desirous outcome will be through a conservative or a medical management, but if it is stress, then it would be a surgical management. So now to differentiate these two, again we'll have to use a clinical knowledge, the evaluation as well as the urodynamic study and the ultrasounds that we do, and come to a conclusion as to which is the most bothersome symptom and most bothersome pathology. So if it is the stress component, then it will be a surgical repair which could be done vaginally, where we put in a mesh to support the urine passage, that is the urethra, or we do the similar procedure abdominally, where we anchor or give a sling-like support to the urethra, that is called a Birch suspension. Robotically, when done, it gives a better superior results. It can be as well done laparoscopically. But if it is the urge symptom which is more bothersome for her, we would first try with medical management, try to control her symptom, and then if that also doesn't work, then there are minor surgical procedures where we do cystoscopy and Botox instillation, sacral neuromodulation, all that as a higher modality to control the bladder's overactivity. So if one of the bothersome symptom is solved, then we look into the other bothersome symptom, if at all, if it is present.
As a staged
As
treatment.
a staged and a stepwise procedure.
Thank you so much.